introduction to our Caribbean and African Targeted Health Improvement Program, CATHIP Health Hour. The Caribbean and African Health Network, CAHN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating, and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members, and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses, and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell, and many more. We have not forgotten to include within our health hours the many societal, cultural, religious and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@carn.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.
Hello again, it's another Saturday and a very warm welcome to every single one of us. Once again, it's my pleasure to welcome us all to this CATHIP Health Hour session. My name is Dr. Diana Santi and I'll be your host for today. This is our CATHIP Health Hour session. CATHIP is the Caribbean and African Targeted Health Improvement Program. And this health hour is delivered in partnership with CAHN, our Caribbean and African Health Network, the Black Health Initiative, Croydon BME Forum, Enfield Caribbean Association, RAFA International, the Royal House Redeemed Christian Church of God, Sheffield. And we have a very exciting discussion today. As usual, we bring you different health topics week in, week out. And today we have a very important, knowledgeable and experienced resource person to give us a session on a very important area of our lives. So we'll be talking today about the link between diabetes, high blood pressure, and chronic kidney disease. And it is my pleasure and singular honor to introduce to us Professor Ibi Erekosima. Now, he is a physician at the Royal Salford Royal, I beg your pardon. He also is a lecturer at the University of Manchester and does some work with University of Port Harcourt in Nigeria. For those of you who know Nigeria, he's a facilitator for global kidney health. He's a kidney advocate. He's a professor. He's experienced in this area. I will hand over to Prof. At the end of his talk. We will have a Q&A session. I just want to say, please put your questions in the chat box as we go along. Send the questions you'd want us to answer. We will endeavor to answer as much as possible as time will permit. And if we're unable to, there will be email addresses where you can send the rest. So once again, welcome to everybody. And once again, welcome to you, Prof. Erekosima. Over to you. Thank you.
All right. Thank you very much for that kind introduction, Diana. My name is Ibi Erekosima. I'm a kidney doctor at the Salford Royal Hospital in Manchester. And I work for the University of Manchester, also facilitating medical training there, undergraduate medical training, and also do work with University of Port Harcourt Medical School, where I also do facilitate their faculty development in medical education there. And I'm an international facilitator for global kidney health, and got a lot of work that we're doing in Nigeria through partnership with the International Society of Nephrology, bringing kidney healthcare to our communities there. So that's me. So this morning, I'm going to talk about the link between diabetes, hypertension, and kidney disease. I always say that this is a very unwholesome alliance. And that alliance is what causes a lot of challenge to healthcare, even within the UK or other Western world, let alone in developing countries. So I will start. I will share my slides now. Right. So that's me. So the outline is that we'll just look at what diabetes is, how common is it, so that we're aware there's a serious problem. And then we will look at the relationship between diabetes and hypertension and unwholesome alliance, and just look at how it leads to kidney disease. And then look at cardiovascular disease, diabetes, and hypertension together, because they're a real toxic mixture. And just talk about some prevention, which is the most important aspect, and just briefly about treatment, and then take on messages. So what is diabetes? I'm sure people can define this better than me. So everybody knows about diabetes with a lot of information on the internet. So diabetes is a complex group of diseases which is due to high blood sugars. I want to make it as simple as that, not going into the chemical pathways. And then we have two types, which is type 1 diabetes, which is occurs when the pancreas is one of the organs in the body that helps digest our foods, release some hormones relating to food, and gets our body tissues to get its food. So it's when the pancreas does not produce enough insulin, which is a chemical produced by the pancreas. But they also have type 2 diabetes, which is called non-insulin dependent formally, because previously it was thought that people who had this disease did not need insulin. But actually it's characterized by insulin resistance and relative insulin deficiency. But just interesting to say that we use insulin to treat type 2 diabetes now, and a lot of other newer agents. So what is the difference then between the two? I just want to highlight some areas for your own knowledge. Is that one starts early in life, and the other one is over 30 years old. And then one is associated with excess body weight, which is type 2, when none is not. And then one is associated with when the body is starved of glucose, although you have a lot of glucose, but the body is starved because there's little insulin. So you have what we call ketones, which the body now converts to use energy, because glucose is the greatest source of energy in the body. And on the other hand, this is the type is associated with high blood pressures and cholesterol. The type 1, you need insulin pumps and things, but type 2, you can do lifestyle modification, where we're going to focus more on that, and with tablets. So sometimes you can go off tablets if your lifestyle modification is pretty good, and it now brings down your glucose level to the point that you don't need medications. I'm sure my colleague Diana will be able to will agree with me with that, and the other one cannot be controlled without taking insulin. So these are the key differences of the two. So what is the extent of the problem here in the UK? If you look at figures from the UK diabetes data, you could see that in 1996, there were just 1.4 million people diagnosed with diabetes. But in 2019, there are 3.8 million. And so you can see the evolving changes, and that is a bit scary for even as a government to provide delivery to people who will be affected by this disease and all the complications. And then the other data too from the UK Diabetes UK, Yeah, 90% of people have type 2. So you can see that the type 2 is more related to lifestyle, and rather than type 1, which is more at a young age due to some destruction of the pancreas. So I'm not going to talk about the 2% that have rare types of diabetes. So if you look at this cartoon here, ethnicity and type 2 diabetes risk is South Asian people living in the UK are up to 6 times more likely to develop type 2 diabetes than the white population. White people of African and Caribbean, it's a little bit less, 3 times more likely. So you can see that we are at a higher risk of developing diabetes compared to the rest of the population. And if you look at this, this is also another data from the UK, Diabetes UK. All this information are on the internet. And so if you look at, I'll just focus on Black Caribbean, the men 5%, the women unfortunately have less risk than the men. And I don't know the reasons why. Probably we eat too much. You know, we have large meals as race and things. So, but if you look at it, that's but you see that is something that we should think about. So, what's the link then to kidney disease? I'll talk about this and then I'll bring in hypertension into it. So, diabetes can lead to kidney disease, and which is the commonest cause of kidney disease worldwide. So, when we look at the studies done every part of the world, have shown diabetes to be number one. And it's because the filters in the kidneys are damaged by the poor glucose control. And it's usually called nephropathy or diabetic kidney disease. And 40% of people, you can see that's almost half, have chronic kidney disease during their lifetime. An estimate of prevalence of this is between 18 to 30%. Prevalence, how common it is. So that's something that is what's also reflecting on. So what is the two? Why was the two come together? Diabetes on one side and hypertension on the other side. And so this is where it's interesting to see that both of them are lifelong chronic diseases, which we need to manage and cope with. So what is the relationship between the two? Now, I've talked about how diabetes is a common cause of chronic kidney disease, but I just wanted to take a step back to bring in hypertension. And so I have to say it's twice as frequent in patients with diabetes compared with those who do not have. This is very true. And so virtually everybody who is a certain age with diabetes is type 2 diabetes, who will have high blood pressure. So there has been this association with the thing that the resistance to insulin and all that are putting them at risk of developing hypertension. And so what happens is that these are the two leading components of global chronic disease, and the common causes which I've just mentioned. Type 2 diabetes dramatically increased 2 to 4-fold your chances. If you have the two, you have a 4-fold increase of having cardiovascular disease and end-stage disease and double dialysis, and possibly death, which is something that we don't want, compared with the normal population of non-diabetic adults. So if you look at these two diseases, and those that don't have it, you can see the increase in kind of cardiovascular disease and those that end up on dialysis or have a kidney transplant. So this bi-directional relationship between the two is of significant public health importance and about disease prevention and management of complications, which I will just touch a bit later. So going forward, it's the same thing. So this suggests the importance of keeping an optimal glycemic control, which is blood sugar control in general population and blood pressure screening. And so the point I want to make here is that if you have type 2 diabetes, your likelihood of having high blood pressure is very high. And if you look at this data that was done by a research group in 2019, 85% of those who have type 2 diabetes have high blood pressure. Only 6.9% of hypertensive are diabetic. And so this is a very big study, which we refer to. And so this gives you the fact that if you got diabetes, type 2 diabetes especially, your chances of having hypertension is very high. So I put this cartoon just to remind us as a cultural thing. So chronic kidney disease is there, diabetes is there, hypertension is there. So they're all, I always say that they're conjoined twins, they're all tied together. And so if you look at the risks of chronic kidney disease the risk of having chronic kidney disease, you see diabetes, high blood pressure, and you link it to heart disease, because I've shown in my previous slide how these two can cause this. And then I'll show you another slide later. Well, if you have this with all this, it becomes a disease multiplier for heart disease. So you got obesity, you got family history. If you have a family history of hypertension, you're likely to have hypertension and diabetes, and type 2 diabetes. And then smoker, and then those that are above age 60 years old. But I just want to mention that related to age, when I look at most of the data, especially from Africa and particularly Nigeria, most people that are identified with high blood pressure are in their 30s. So that really makes one very concerned. So how common is chronic kidney disease in the UK? So I just want to remind ourselves that you can see that uncontrolled diabetes and high blood pressure are the biggest cause of chronic kidney disease, which I've mentioned before. And then I've just put out the key points here. The Black, Asian, and minority ethnic groups are 5 times more likely to develop CKD, which is chronic kidney disease, than other groups. So this is that. Sorry for that typo. And every day, 20 people in the UK will develop renal failure. So if you are 5 times more, so that means that you'll be in this population. So that is something that we need to, and that's why these two diseases, diabetes and hypertension, are things that we need to take very seriously. And deal with it from the foundational level. So this is another cartoon showing that the commonest causes of kidney disease. You can see that 42% are diabetic, 28% high blood pressure. The rest, you can see the gap of 7%, 6%, 4%. So I just want to remind you so that you get a picture of how these two affect the kidneys. So first of all, what does the kidney do? And what are the kidneys? There are 2 bean-shaped organs, and they're about the size of a fist. So do your fist, that may be the size, that could be the size of your kidneys. But there are powerful chemical factors that ensure that the chemicals are balanced. They get rid of toxins and unwanted chemicals. And so this is what the kidneys look like. They're more to the back, and the bladder is a tank, and so you make urine, you put it there. I mean, it is put in the bladder. When you're ready to void, you go and void. And so this is the interesting bit. You have what we call filters. There are 1 million filters in every kidney. And so what happens is that diabetes affects these filters. Likewise, hypertension affects these filters. And so just have this picture in your mind. This is the urine is formed and it goes out, through this. After urine is formed, it goes out through this tube. So what does the kidney do? Because the kidney does not just make urine, it controls your blood pressure. And so it is, we used to say the chicken and egg, which comes first. So blood pressure, high blood pressure causes kidney disease. And when you have kidney disease, it worsens the blood pressure. So it causes your blood pressure. So it gets some waste. It also contributes to the health of your bones. It makes sure that your acid and base balance is all right, and it maintains the health of your heart, and also releases a certain chemical called erythropoietin to help build your red blood cells. So how does this now lead to kidney disease? I'll show you another cartoon. The main thing it does is it damages the filters, which I've just shown in the other cartoon. And once it damages that, the kidneys, it's just like a filter in your kitchen. The kidneys begin to filter things that they're not supposed to go through. And some of those things causes more damage to because some of the tissues in the kidneys are not used to that kind of thing. So one of them is albumin, which now filters through and now causes more damage to the kidneys. And so a slight increase in albumin is a sign of, it begins to show that it's a sign of kidney disease. That's why when you go and see a doctor, your GP, they do your blood pressure, they take a urine to test for what they call protein in the urine. And so this is what happens, your kidney disease. Healthy, you can see that the filter is going on well. So these are kept back, the white dot there, but you can see that the diabetic kidney, they're all going through and causes more damage. And so this is just a pictorial thing. Healthy kidney, everything is kept back. The filter is now porous, so it's now getting all this stuff into passing through your filters and causes more damage to the kidneys. So one of the things we say is that once that process sets up, there's what we call progression of your kidney disease. So a protein leaks out of the blood and into the urine. It becomes more difficult for the kidneys to excrete water and salt. And so all the other vicious cycle begins to kick in, including worsening your blood pressure. And then you begin to have symptoms as your kidney disease advances. You get swelling in your feet, you get swelling in your face, feel tired, and a lot of other things. So this is what happens. So in order for us to manage kidney disease properly, you can see the disease kidney there, which I've shown this cartoon in the previous slide. And so you can see that we stage the kidneys so that this reminds us at what level the kidney damage has progressed. And so that's what gives an indication of what kind of treatment and how we can approach the treatment. But what I always say that don't allow this thing to get beyond, you don't want to get here where you have kidney failure. So this is what the damaged kidney looks like. You can see the good kidney. And so we don't want kidneys to be like this. So we need to act early. So this is the symptoms. This is for advanced chronic kidney disease so that you don't misunderstand this. So if you lose appetite, does not mean that you have kidney disease, but advanced kidney disease can present like this. And these are some of the things that begin to remind us that your kidneys are beginning to work less than 20%. And we'll begin to plan the future in terms of dialysis and kidney transplant. So that is diabetes, hypertension, chronic kidney disease. Now, I want to bring in heart disease because heart disease is what kills patients who have chronic kidney disease. And so diabetes, hypertension causes chronic kidney disease. It now worsens, it now catapults the possibility of having cardiovascular disease. And cardiovascular disease, you can see that the factors are hypertension, diabetes, smoking, high levels of blood, lipids, which is cholesterol, and physical inactivity. But these are multipliers, the hypertension and diabetes, of getting cardiovascular disease. And so this chronic kidney disease and cardiovascular disease share common risk factors. You can see smoking, cholesterol, high cholesterol, hypertension, overweight, diabetes, which I've spoken a bit about, and excess alcohol, lack of exercise. So all these things are multiplier effect. You can see that they share common factors. But the good thing is that these factors are changeable. These other ones are not. Age, sex, genetics, and well, this is being debatable now. Sex and age and genetics, ethnicity, you can change where you come from. So those are things that we should remind ourselves about. And so if you look at the connection now, which I'm just trying to connect between cardiovascular disease and chronic kidney disease, having explained the role of diabetes and hypertension causing chronic kidney disease, and as a multiplier effect, it can cause heart disease and make heart disease worse. And also heart disease is a commonest cause of death in patients who have chronic kidney disease. So as your chronic kidney disease gets worse, your risk of developing heart failure increases. And so these are the things that we should remind. So it is, like I said at the beginning of my presentation, they're all just an wholesome alliance. So this is what I brought this to, just to remind ourselves that this is a disease multiplier: cardiovascular disease, diabetes, chronic kidney disease. So you can see that if you have all this, it multiplies your risk of having strokes, heart attack, and all that. So we need to go back and deal with the fundamental issue, which is diabetes and hypertension. So you could see, I put this together so that people will understand that you can see chronic kidney disease, hypertension, like I mentioned, chicken and egg, which comes first, because if you have chronic kidney disease, it worsens the hypertension, and this causes cardiovascular disease and diabetes, cardiovascular disease, and causing chronic kidney disease. we can see that many patients with heart disease also have CKD, which is chronic kidney disease. So that's something that we should also remember. So these are these are 4 serious health issues, because we're here to just enlighten ourselves on how to look after ourselves. So this is something that should remind you that overweight, diabetes, cholesterol, high blood pressure, all put together enhance cardiovascular disease. And so this is what happens for most. I just want to talk a bit about hypertension. The hypertension we have is accounts for 90% of hypertension. This is essential hypertension. So we know that hypertension, 90%, we don't know the cause, but it's usually genetic and all that. And the 10% is secondary cause. I won't go into that technical detail, but just remind yourself that hypertension is something that occurs mainly in Black people. And so how is it important? So people with hypertension frequently have risk factors for cardiovascular disease, which I've demonstrated in the previous slide. And you can see that it's the same thing: overweight, dyslipidemia, sorry for using this word, this is high cholesterol levels, and then overweight, and then diabetes and all that. Blood pressure lowering, good diabetes control equals to reduction in cardiovascular disease. So this is the key organs that hypertension affects, which is similar thing that diabetes affects, which you see in the next few slides that I've mentioned. I keep mentioning that over and over again, but I can't emphasize that enough. So you have the kidneys, you have the heart, you have the eyes, you have the brain, you have the blood. You have elevated blood sugars, which in hypertension, like I mentioned before, if you got diabetes, you're likely to have hypertension. So this is what happens at the micro level. You can see, because it damages the filters like diabetes does, and damages your blood vessels. And these blood vessels are in the brain, in your legs. It can damage the blood vessels in your legs and your brain. And this causes serious morbidity, serious disease, causes strokes, heart attacks, and what we call peripheral vascular disease, which means that your blood vessels in your legs are blocked and you can't walk very far, and all that. And so this is what happens to the blood vessels. It gets blocked over time, which is worsened by your increase in cholesterol and all that. So this is essentially the cardiovascular disease and diabetes. You can see the link. In the previous slide I showed you about the hypertension. You can see that they're all the same. Your increase 2 to 4-fold increase in strokes, cardiovascular disease, coronary heart disease, heart failure. And so you can see that they are just the same story. And the same thing at the small vessel level, it affects the nerves. It's also the same thing. It affects the strokes, it affects your eyes, and also affects the kidneys. And so you can see the relationship there, which is really what causes serious problems if you have diabetes. So what's the treatment? The key thing there is no cure for diabetes, kidney disease. And so treatment consists of keeping your blood sugars under control. Blood pressure should be within target through medications and lifestyle changes. So the key word there, how do you even get here? My take on this is that you don't allow yourself to even get here. So you need to look after yourself. But if you have the disease, these are the key things. There's no specific pill that will give to repair your kidneys. You need to deal with the risk factors. So we give medications to treat the high blood pressure and to reduce the protein in the urine. And so this is what happens. Treatment is aimed at a specific cause. So, but as a kidney physician, once you see me, one my aim is to slow the progression of the disease, and as they get advanced, we manage the complications. But this is where I don't want anybody to get to, because it's awful. So getting to dialysis and kidney transplant. So if we now think back on all the things I've said from the beginning of my talk, this is where I don't want people to get to. So you just begin to work. So that's why I bring this up after this slide. So how do I prevent complications in diabetes? So the risk of developing complications can be reduced by By a number of healthy lifestyle steps, achieving good control of your diabetes, losing weight if you're currently overweight, eating a healthy, balanced diet. But I just want to warn you that there's a lot of information on the internet, which is giving all sorts of very bizarre advice. You should be very, very wary of that. Make your life very simple. Eat balanced diets, fresh vegetables, and try and take some exercise at least 2.5 hours every week, which is easier said than done. And then low alcohol, reduce your alcohol intake, and then quitting smoking. See, I did say that just stop alcohol altogether. I mean, you take a glass of wine, which could be good. For red wine, they said that it's good for the heart. There's some evidence there, but it's still debatable. But you quit smoking. So this is a picture just to remind you, taking your medication to control your blood pressure, managing your blood glucose properly, managing your diet, changes in eating, lifestyle, and then losing weight if you're obese, and then getting regular physical exercise. You don't. Some people think that you have to enroll in the gym if you walk 30 minutes 3 times a week, or 4 times a week if you can. That will give you about 1.5 to 2 hours in the week, and that could keep your weight down. So how can I keep my kidneys healthy? So it's the same thing that I've just said. Actually, all of them have a common template, which is regular physical activity. Losing weight if you need to, else eat less fat, keep your blood sugar, blood pressure, and body fat under control. So stop smoking and keep yourself well hydrated as well as you can, because in this country, people don't drink much. That's another matter that we'll discuss another time. That refers to also to kidney stones, and then reduce stress. But that's something that is very debatable. How do you reduce your stress? But it's something to think about, especially when you have high blood pressure and diabetes. So preventing chronic kidney disease and cardiovascular disease, these are the endpoints of diabetes and hypertension. So cardiovascular disease, which includes having strokes, having peripheral vascular disease, ischemic heart disease, which is the heart. So we need to say that 1 ounce of prevention is worth a pound of cure. So diet and exercise to maintain a healthy weight. To talk about smoking cessation, control diabetes, control blood pressure, control cholesterol, avoid excess over-the-counter drugs, and then herbal preparations. I was in a talk sometime where people were asking about some of those preparations. People boil all sorts of leaves and drink and all that, but I think there's no evidence that most of those improve organ function. So you need to be careful. Regular checkup with your primary care physician, like Diana, who is a primary care physician. So this is something that you should think. So now I want to conclude with some of these slides that busting the myths in hypertension. Now, hypertension is not a temporary illness that will resolve, just like diabetes. The absence of headaches and dizziness does not mean good hypertension control, because people link symptoms to taking their medications. There's no need to experiment with stopping treatment to see if symptoms will reoccur. And do not stop medication because of lack of symptoms. And then on this side, I did put that. So do not wait for symptoms before you're taking medication, or do not stop medication because of lack of symptoms. So those two is the other way around. Long-term medication is not harmful and does not have any risk of tolerance. Dependence on drug builds up to harmful level. But there are some medications that people are not able to tolerate. They can change it to something more tolerable, but you need to be on medication long-term, which is lifelong. Alternative medicines are not more effective. They may result in complications, and too little, too late. We've had a lot of situations like that where people, especially from our ethnic background, I have a couple of them on dialysis who have done this. And so we should be aware of this. And so I put this, know your numbers, in order to deal with kidney disease and cardiovascular disease under the platform of hypertension and diabetes. So healthy eating, smoking cessation, physical activity, reduce alcohol consumption, weight management. I think I've said this about 5 or 6 times now. So there is so much, it's so important that we need to do this. So one of the things that you do want to end up on one of those slides that I put up, which is dialysis or transplant, if your kidney disease advances when you get a kidney disease. So look at what I've said here. Testing over 40. So if you're over 40, you need to talk to my colleague, Diana, who is a primary care physician, to be able to do check this for you. There's this well man programs and well woman in between primary care, but I don't know whether those funding still exist. I probably should say a bit about that. But this is something that will be valuable to you. They'll do the basic checks, and these things will tick the boxes that I've just mentioned. And so finally, you can see that kidneys and heart, these are the 2 organs. And then if this are well controlled, then things will be better. You talk about habits, compliance to medications, healthcare, environment, genes, food, exercise. There are some that you don't have control over, some you have control over. But the key takeaway messages is that just be aware that chronic kidney disease, cardiovascular disease, diabetes, and hypertension are all very common and interrelated. Lifestyle is as significant risk factors. Poor diet, lack of exercise. Prevention is key. So health check with your primary care physician is important to screen for and manage these diseases. So this is just in a nutshell, just to remind yourself how these 3 cardiovascular disease, hypertension, diabetes, cardiovascular disease are interrelated. Thank you for listening.
Thank you.
Take questions now.
Thank you so much, Prof. This is really, really useful, a very important, well, not a triad, but more of a multiple, correlation that you've talked about, the link between blood pressure, between heart disease, between kidney disease, and how we can prevent these things. We have been taking questions in the chat box, so please feel free to put your questions in there, because we're in the Q&A session now. Prof, you've really given us a lot of information. So just some of the things that you said, the important link between all of these, the massive burden on the nation and global health of the impact of diabetes and the other things that people can have as a result of having diabetes. The fact that if we have diabetes or we develop diabetes, we have an increased risk of developing hypertension as well. The fact that if you've got diabetes and hypertension, then you have even an increased risk and a multiplier effect for developing kidney disease. The fact that when you have these 3, it also impacts your heart, your health, your kidneys, everything. And the fact that the things that we cannot do anything about, like our age, our ethnicity, our race, you can't do anything about that, but there's a lot that we can do a lot about. And we need to focus on those things so that we can do something about those. Just before the questions, I just want to chip in quickly based on what Prof said. We do still run the well woman and well man checks. So please do see your GPs about those if you need to. So we go on to the Q&A sessions. There are already a few questions. So first and foremost, some of the questions for you, Prof. Can someone be a type 2 diabetic and be on insulin? So can someone be a type 2 diabetic and be on insulin? Thank you.
Yes, I knew that question was going to come. I did mention in one of my slides that, yes, I mean, about decades ago, it used to be taught that when you have, they used to describe type 2 diabetes as non-insulin dependent. Well, that thinking has changed over the last several decades because it's been found that it's due to insulin resistance and lack of tissue sensitivity to insulin. And so the answer is that right now, the thinking is that we can use insulin to treat type 2 diabetes because of the research findings that have been around for decades now. So we can use insulin because we found out more things how type 2 diabetes happens and the way it affects the body.
Thank you. So yes to that. Thank you so much. And someone is also asking that she's noticed that patients with polycystic kidney disease sometimes experience a lot of itching. What causes the itching?
All right. So that's also important. I mean, polycystic kidney disease on its own with normal kidney function does not cause itching. It's not a recognizable cause of bodily itching. But if you have polycystic kidney disease and your kidney function begins to go down, which usually it will do, so by the time your kidney function begins to get to GFR, so the kidney function of around less than 20%, one of the things happens is that your kidneys will not be able to control phosphate and calcium, and that deposit in your skin, and that can cause itching. But what if you're on the other spectrum where your kidney function is normal and you have polycystic kidney disease, you will not have, it doesn't cause itching. But if your kidney function goes down to less than 20%, like any other cause of kidney disease, you will have bodily itching because of what I've just explained.
Thank you. Thank you. And also another person is saying that there is some sort of feeling that people have that if they are on long-term blood pressure medications or diabetic medications, the medications can damage their kidneys, and therefore they are sort of resistant towards taking medications, or they're not keen on taking these medications because they think the medications will damage their kidneys. Is that the case? And is there any evidence from research to support this concern?
Yes, I mean, that's also an important question. So what happens is that, I mean, if you're having high blood pressure, which is uncomplicated, your medication does not cause effect on the kidney. Now, there are situations where the type of kidney disease you have, if you have narrowing of the blood vessels to your kidney, there are certain medications that we are cautious in giving you, and we give you alternative medications. Now, what I'm trying to say is that if you have high blood pressure, there's no evidence that medications cause the medication that you're taking for your high blood pressure is going to damage your kidneys. There's no evidence like that. And so what I will advise is that you should take your medications. And if you're not tolerating your medications, you should see your GP. Now, I'll talk about diabetes. Diabetes, there are certain medications which there are knows about. Metformin, it's advised that if your kidney function goes below 30%, that you should not take it. Now, it's not taken not because it causes damage to the kidneys, it's because if the kidneys eliminate metformin, is the only route which that drug is eliminated, so it doesn't cause toxicity to your body. So if the kidneys are not clearing toxins well at less than 30%, if you take it, metformin now accumulates in your body, increases what we call lactates, which will be damaging to your body. So that's the reason why some medications like I said, metformin in diabetes, we stop it when your kidney function is less than 30%. But there's no evidence that metformin on its own causes kidney damage.
Thanks for clarifying that for us. So it's important that we stick to our medications which we are prescribed, and if we have concerns, discuss them with our doctors. If you have kidney disease and your kidney is already burdened, then we would not want to give you medicine that will put an extra burden on your kidneys. But there are always alternatives. So please don't just stop taking your medications. Speak to your doctors about your concerns. Prof, if someone is craving for sweet things all the time, could that be a sign of diabetes? If they're always craving sweet things, that's a question on the forum as well.
Yes, I mean, there's no evidence that you're craving for sweet things. There's no evidence where they followed up people from their young age that because they've eaten a lot of sweets, that's why they now got diabetes. Now, even if let me just give you an example. If you like take a carton of sweets and then somebody is eating a full bowl of gari or something every time, you will have the same glucose content in your stream compared to those sweet things. But the thing is that as you grow older, your body's capability of of handling what called refined sugars are dwindling. So you must be careful when you're taking refined sugars, which are more in sweets.
Okay. Thank you on that. Any, I know you touched about the natural products or slightly about, people using concoctions and natural products and things like that. Now, someone is asking, would like to know, is there any role at all for natural products in the treatment of diabetes or hypertension? So there's no specification of which product in particular, just generically, is there any role of natural products for treating diabetes or hypertension or indeed kidney disease?
Of course, Diana is laughing because the natural product is go and buy fresh fruits and vegetables. That's a natural product. There's no evidence that you go and get all these things like what they say, you just have to, when you have the disease, this is when you have the disease, that you go and take all these products is going to, like some people, especially back in Africa, they have bitter leaf water. They take all this carica papaya leaf, they boil it and all that. Those things don't have, there's no evidence that it has any benefit. But eating fresh vegetables and fruits and lifestyle changes will be able to help you with your weight reduction, with your blood sugar control, and also cholesterol levels and all that. But there's no specific natural product you have to go and buy in the shop. I would say that this is a magic one that will help you. I've not seen one.
Thank you. Thank you for clarifying. And just to add to what Prof is saying, I think it's also sometimes difficult because medicine is an evidence-based science. And so without, people sort of doing studies on certain things and looking at the evidence behind it, it's difficult to validate certain things. So it's normally difficult when, a clinician is asked something about something which is natural or things that haven't been passed through the rigorous testing and research and validation. So that's another challenge which makes it difficult to comment on things like that. We just don't have the evidence behind it.
Can I just jump in? Look, I just saw a question concerning this. Somebody was saying that, that drinking this every morning is good for your health. What health? Is it health that your foggy brain is working? Or what health are you trying to say is good? So you might be doing other things, doing exercise, which is actually helping your health, but drinking those things is not helping anything. It's just that thing in people's brains that, if I do this, there's a lot of stuff on the internet and all that. But all the people I've seen that have taken these products have ended up with organ damage. Yeah.
Right. Thanks for that as well, Prof. So for someone who has type 2 diabetes, what should be their blood pressure reading to avoid risk of kidney disease? And also being treated for kidney infection, could that increase your risk of kidney disease? That's the question.
Yeah, the first question is that when you have kidney disease and you have high blood pressure, we tend to get the blood pressure lower. For example, for the normal population who have uncomplicated hypertension, we say that your blood pressure should be less than 140/90. Now, for anybody that has kidney disease, what we're trying to get it down to 130/80, less than 130/80. Now, if you have a lot of protein in your urine because of diabetes and hypertension, we bring it down to 125/70. But the 125/70 is a cuckoo land. I mean, that will not happen. So we tend to be realistic. For me, as a kidney physician, if your blood pressure is less than 130/80, I'm happy.
Okay. So those are the numbers for those who want the numbers. So a question in relation to, given the rates of kidney disease in the Black community, how can we request blood tests from our GPs to check our kidney function? And when should we request these? Being a
it's
GP,
over to you now, Dan.
Being a GP, I'll quickly answer that. So you are able to request kidney function blood tests from your doctors if you've got concerns. I mean, the thing that people don't like about coming to say, oh, I want this blood test, or I want that blood test, is, with no disrespect to patients, sometimes you might think that's a blood test that you need, but there might be another blood test that you need in addition, or there might be something more suitable. So I think it's important that we raise what our concerns are and then have the discussion with the doctors so that the appropriate test can be done. Because you can imagine that if you are concerned about kidney disease and you go and say, oh, I want a blood test for kidney disease, and they do it, and they later realize, oh, maybe it would have been useful to check your blood count. It could have been useful to check your liver. It could have been useful to check whether you were diabetic as well. And then, you end up with multiple visits, and it's hard enough getting in to see your GPs anyway. So please, if we have concerns, let us speak to our clinicians, our GPs, discuss what the concern is, and then the appropriate blood tests can be raised for you. And you can have these discussions at any time. There's no specific time. There's some people who need regular monitoring because of medications they might be on or conditions that they might have. But if you're not diagnosed with anything and you have a concern, just discuss it. I don't know if Prof has something else to add to that, please.
No, you've said it all. I mean, if you're concerned about something, you can't just wake up and say, oh, well, I've read on the internet that, oh, kidneys, this affects Black people too much. So you just say, I need a blood test, please. No, you have to discuss your concerns with your doctor, and people can have a plan on how to deal with it.
Thank you. How can voluntary organizations support people in the community to manage cardiovascular disease? So for instance, people with high blood pressure, what might be the approach? So someone is put a useful suggestion and saying the Barnett Borough are able to deliver a project to the Africans, the Caribbeans, the South Asians. So I guess any thoughts will be useful to post in the chat. But again, programs like these. And Prof, how else do you think we can, sort of create that support network in the community for people with the things that we're talking about today and other conditions as well? What more can we do?
Now, this forum, the Caribbean African Network, is an excellent example. I mean, where they have kind of a talk every Saturday, and they are advising on lifestyle changes. And these are the key things. I also say that there's no rocket science to this. There's no real magic bullet, So, I mean, I was, if you look at the adverts that Faye put up, she said most people, because we as Africans and Black people, we're very religious people. I mean, that is not in doubt, which is a good thing. But that is sometimes taken too far when we are faced with the reality of life, and especially health challenges. So that is one thing that also this network is trying to address. So useful information, things that will disabuse our minds, and how to live healthily.
Thank you. That's really important, isn't it? Because those are the things we've got control over. Those are the things we can do something about. And it's all about what we can do something about. And also CAHN is always ready to receive more suggestions. And if people have ideas that they also want to contribute to or set up groups, please feel free to contact CAHN. The email is health@cahn.org.uk. Prof, if someone has chronic kidney stage, for instance, stage 4, is there a possibility it could improve back to stage 3 or even to stage 2? Someone would like to know. And also, what are the factors? Okay, I'll leave that question until you finish this one, because there's slightly 2 different themes. So could it improve if we got kidney stage 4, for instance? Can it get better?
Okay, I did put in my slide there that the answer is no. This is called chronic kidney disease. So it's slow and progressive. So my job is to slow the progression. And there are certain factors we look at progression: your blood pressure, your diabetes control, presence of protein in the urine, and other things, associated cardiovascular disease and all that. So the answer is you cannot bring it back to stage 2, the figures there. That's why it's called chronic kidney disease. So what we do is that we slowly progress. There are some people that they just stagnant there. They don't lose any kidney function for years and years and years, and because the risk factors are taken care of. So the answer is no, you can't get it back. But there's a caveat there. There's a certain types of, if you're well and your kidneys are okay and you have an acute disease, where, for example, your kidneys are working at 90%, and all of a sudden you find out you have infection and dehydration and got into hospital, your now kidney function goes from 90 to 20, likely that it will go back to 90%. Okay. So that's the difference. But if it's chronic disease, it's not going to go back.
So the chronic is the slippery slope, and basically we are trying to slow down the progression. But if there's an acute something, an infection, or you're not drinking enough, or you've gone into hospital or something and it gets worse, then hopefully that can improve. Is that right?
Yes, that's it.
Thank you. Thanks for the clarification, Doc. Prof, sorry. Please, what other factors does diabetes affect in terms of homeostasis? What are the other factors that it can? I'm sure you've talked about that in your slides, but someone would like to know maybe briefly what other factors does it affect in terms of homeostasis?
Yeah, I mean that's a very technical word. People will not know the meaning of homeostasis. Homeostasis means balance. You know, keeping a kind of a balance in your body so that the organs are functioning well. I mean, the factors that will keep a balance of your blood sugars is essentially doing the things that we just said. I mean, lifestyle changes, taking your medications for diabetes and all that. Now, you should also understand that the diabetes itself, you know, affects the eyes. If the diabetes itself affects the nerves, so you should know that there are other organs that affect your muscles. It's a awful disease that affects virtually everything. So the key thing here is to make sure that your lifestyle changes to help reduce your glycemic level, which is your blood sugar levels, and then medications, working with your doctor to make sure that you do the right things. And then the things that you have control over, which is the blood pressure, which is the lifestyle changes you have to do.
Yeah. Thank you. And that links in beautifully to the next question, which I think Prof has answered a few times already. It says, can I ask what the alternatives are to chemical medicine for high blood pressure? So Prof has touched on that. If you don't want medications, then you really need to hone in on those lifestyles. But sometimes there's only so much your lifestyle stuff can go, and you might get to a point where you need medication. So he's talked about that. We move on to the next question. Is high blood pressure genetic or hereditary? Prof, is it genetic or hereditary? And so are you more likely to develop kidney disease? Yes, he has said we are more likely to develop, but just to clarify for someone, is it genetic or hereditary? And what do the two mean? Is there a difference? What do they mean? Just to clear our mind.
When you say genetic, means that you can transfer it through your genes. Hereditary means that it is transferred from generation to generation, isn't it? So it's through the genes that it transfers from generation to generation. So it's hereditary. So they say the same thing, but they convey different messages, but they say the same thing. Yes, it is. If your parents are hypertensive, you're likely to have high blood pressure as you grow older. You might not be have high blood, but you found that if you look at the data that I've done quite a bit of literature search in Africa, and there's a lot of work we do there. The people that have high blood pressure compared to Caucasians is, if you look at the age match, is different. Averagely, you see somebody in their 30s with high blood pressure. It is very unlikely to see a 30-year-old Caucasian with high blood pressure. Why is that? It's because that is most of us have a family history of high blood pressure. I have a strong family. My father, my mom were both hypertensive. My grandma was hypertensive. So that's what we should understand. And this study has been done even with the African Americans in the Framingham study. So it is a disease of Black people.
Yeah. Now, Prof, we do have quite a few questions, so I'm going to begin to combine some of them for you, if you don't mind, please. So one of them says, what are the signs of kidney infection? Okay, so I don't know whether they want to say kidney disease or kidney infection, but if you can tell us briefly what the signs are of kidney infection, and briefly what the signs are of chronic kidney disease, that would cover that. Drinking bitter leaf every day, is that good for our health? So I think Prof has already touched on that. Using natural honey, have you heard about it, Prof? Okay, So I'll give you those three for the meantime, and then we'll move on to how can people who are on long-term steroids avoid developing diabetes. So we'll crunch those for you, and if you can give us a spiel on all of that, and then I'll give you the next batch, please.
Okay, so just quickly about urine infections. Urine infections, when you say urine infection, bladder infection seldom affect the kidney function. But there are certain urine infections due to structural damage to the kidney. So you are prone to urine infection compared to somebody who does not have structural abnormality. And so, two words. One, if you just have a simple bladder infection, it hardly affects your kidney. But if you have, maybe somebody was born with some structural abnormalities in their kidneys, could have water infection. And that's why if you look at both male and female, females have a higher incidence of, higher occurrence of kidney infection compared to males. So that's now the kind of symptoms of urinary infection. Of course, you find that when you're passing urine, you find pain. Sometimes you feel under the weather, and you'll be passing urine frequently, and you pass very little. It will be frequent, and you also have pain when you're passing urine. Now, in terms of the symptoms of chronic kidney disease, I did put it on my slide. Most times, if you have chronic kidney disease, you don't know about it. The symptoms begin to kick in when your kidney function is getting to stage 3B, which is a situation where your kidneys are beginning to work at less than 40%. So at that point, some people might begin to develop swelling in their feet. Of course, their blood pressure is going to be high. But as your kidneys begin to deteriorate to less than 20%, you begin to have poor appetite, itching, poor sleep. There's a lot of gamut of symptoms that you begin to get. But naturally, if you got kidney disease, most times, stage 2, stage 3, most of people don't know. I've had people who are just walking the streets and they just went for insurance check and found out that their kidneys are working less than 20%. I've seen patients like that who they referred to me. So that is something that you should know. So that's why it is important that after age 40, I did mention there, do the well man, well woman kind of health check to be able to find out some of these things.
Thank you.
I don't know whether I told you I have a short attention span.
Putting it to the test there, Prof. So the next one was the bit about steroids and developing diabetes, please.
Okay. So just before that, I just remembered one of them in terms of bitter leaf. I've said that there's no evidence that bitter leaf causes that helps you in any way. But people think that taking some of this will give them that sense of well-being. But one thing that I always tell people to be careful that always think about your organs when you're taking some of these things, because there's no benefit. What are you trying to detoxify? Is it your kidneys, which is detoxifying your body? It's a natural thing. And I don't know what that will do, in terms of, I've had even doctors, colleagues who have been taking bitter leaf and said they have diabetics and taking that. And I've said, look, hey, I think you know the damage you're causing to yourself. Now, coming to steroids, if you look at the way steroids work, once you're on steroids, your diabetes gets worse if you have diabetes. And there are people who are on long-term steroids, like people with kidney transplant, who eventually have diabetes because they're on steroids for a long time. So one of the things we do is to alert you that, look, this is what's going to happen, but the benefit of steroids outweigh the risk. For example, if you don't take steroids as a kidney transplantation, your kidneys will be rejected. If you have some inflammatory diseases, like you have some of these diseases, you see that your kidneys will be affected. I'm sorry, if you have inflammatory disease and you don't take steroids, you see that your kidneys will get worse. So it's risk-benefit ratio, and that has to be discussed with your doctor who is prescribing the steroids. They're all aware that you have a high risk of increasing your blood sugars. But if you have diabetes, they will increase your diabetic they will adjust your diabetic treatment while you're on the steroids. That's what happens.
Thank you. So I think it brings us back to the point that you said, that the essence of this talk is for us to not get to that point in the first place, not get to the point where we're developing diabetes, not get to the point where we're developing hypertension or kidney disease. Because sometimes we do get to that difficult crunch point where we know that some of the medication might have an impact, but without the medication too, you're between the devil and the deep blue sea. So Prof has emphasized so many times today that let's not get to the point within our power where, you know, we become diabetic or our diabetes is not well controlled, etc. And so the things we can do to help ourselves, please, watching our weight, our diet, exercising regularly. People can buy a blood pressure machine, keep an eye on your blood pressure, exercise, you know, drink lots of fluids, all those things. Please, let's help ourselves. But thank you so much, Prof, for driving that point home. Can I crunch a few more questions for you? Why are Blacks more affected? And I guess this is in relation to the kidney disease side of things, but also to the diabetes. Is there any research to support why African and Asians might be more affected? So that's the next question for you, please, Prof.
Yeah, I mean, there's a lot of data there in the UK, Diabetes UK. But this data was taken from there. And it is very true that that is what it is. And it's probably, some of the things they've explained is that it has some bit of genetic basis, which, especially the Asian population, they have type 2 diabetes. And also, the diet too is one contributing factor, how we eat, and most of our foods are very carbohydrate based and all that. So those are things that we have to bear in mind. But just to let you know that this is an extensive study that was done, and published. It's on the internet. It's not hidden. If you go to Diabetes UK, you get those data there, the information.
Thank you. Sorry, my chat box is slightly frozen, but I will not panic. I will just keep calm and keep scrolling down.
I just saw before you as you're going, I just saw somebody say vitamin D, is it good for your kidneys? I mean, that is a good question. Vitamin D is one of those vitamins that is handled by the kidneys. Now, what it does is that it activates once your skin gets the cholecalciferol and then passes to which is the chemical, now passes to the liver and then passes to the kidney. It makes the vitamin D active. So most people with kidney disease, there's lack of active vitamin D. So we give them vitamin D to help with their bones. But vitamin D on its own does not help prevent kidney disease. It doesn't.
Okay, thank you for that. Yeah, so a few questions, which again, some of them have been answered. So because of the number of questions, I might just touch on those briefly. So if a type 2 diabetic patient manages to have their blood pressure under control, could they stop their high blood pressure medication? So Prof has already said, don't just stop your meds, speak to your doctor. And so that will be the advice. And also, is passing colored urine a sign of kidney disease? What are the signs of kidney disease? Prof has talked about that a few times already. So is passing colored urine or drinking excessive water during the day and nighttime, is that a sign of kidney disease? I guess it's still part of what you've said, but if you just briefly, yes or no to that, it would be great for us, please. Thank you.
Yes, I mean, that's a quite important question, because when you now pass large volumes of urine, it depends on whether you're a man or woman. I mean, it depends on your age. If you pass loads of urine, I mean, if you're drinking more, you pass more. That is that. And then that's not a good sign that your kidneys are affected. But passing a lot of urine, large volumes of urine, could be a sign of other things. But if you're drinking and you have to pass, the kidneys is there to get rid of the excess water. So you have to pass urine as you're drinking more. But if you're not drinking more, you're passing large volumes of urine, then there's something wrong. But that's not an indication. Even when you have diabetes, if your blood sugars are high, it can make you go to pass urine more and all that. And then, if you're passing a little amount of urine and then go there, then you have pain, that's a sign of urinary tract infection. But it's not, large volume urine is not a common indication of kidney disease. So you should bear that in mind. I don't know whether I've answered your question.
Yes, please. I think you've answered the question. I think also maybe the person is thinking along the lines of diabetes as well, that if you're passing a lot of urine.
As if you're not drinking enough.
If you're not drinking enough and you're passing a lot, then could that be a sign? So as Prof has said, yeah, that could be a possibility, but it's not a diagnosis. Still go and see your doctor and get checked. Prof, please, why does diabetes, cause problems with the eyes and the feet and the nerves? Why does it affect all these organs? And also, why is it that, if you put on a lot of weight, you can become diabetic?
And what happens is that, let me take the first part. When you have diabetes, what happens is that you're just like you're in a warehouse where you have food, but you can't take it. That's the way the body is. So the body has to have alternative ways of dealing with that excess food. I mean, otherwise, and so it now converts it to glycated products, which I don't want to use those technical terms, but it's also some chemicals that are not going to be useful. So those chemicals now deposit on the tiny blood vessels in your eyes, in your kidneys, and also that supply your nerves. And that's why it's called a microvascular disease. So it affects the nerves. So the same thing that happens in the eyes that happens in the kidneys. So and same thing that happens in your nerves. And what happens with your nerves is that you begin to not lack of sensation in your feet, and that also leads to if you get injury, you wouldn't know, and all that. So I think that's what happens. That's why they have that problem. Now, the other thing about obesity, if you're obese, your body, it will expose you to insulin resistance because you got a lot of fats. And so your tissues are not responding to the insulin that is circulating, released by your pancreas. And so your blood sugars will go up. But if you lose weight, your body will begin to say, yes, now we can absorb some things. And because all the excess fat is burnt off and all that. So that is, now somebody is saying, I forgot to ask about colored urine. Depends on when you say colored urine, what color is it? I mean, if you have a concentrated urine, the color, if you're not drinking enough, your urine will be concentrated. And so the color will be darker than usual. Now, if you eat certain foods, if you eat beetroot or some of these things, your urine will change color. So it depends on what you say. You have to be specific about color of urine. So changing your color, you also think about what am I eating? Or am I drinking enough? So, and then in terms of what we see in the urine that probably will give you some alarm is when your urine becomes very, very frothy. And so frothy means that probably you're leaking protein in the urine. But also don't use that to be, because my urine is frothy, so I need to call my GP. But sometimes if you're not drinking enough, it's concentrated, it can be frothy. But frothy urine is one thing that frequently gives a sign of chronic kidney disease, because you're leaking protein in the urine.
Okay. Thank you for that very important point, Prof. So, Prof, on the flip side, why can someone be obese and not have diabetes, and someone might be slim and they end up having diabetes? And also, another question, will you advise keto dieting? Does fat or protein have any dependence on the kidneys? Three in one for you.
Okay, so now the question that if you're obese, I mean, there's enough evidence that obesity and diabetes go together. So it is difficult to see. I've seen patients who are young and obese who have not had diabetes yet, but they will get diabetes eventually. Because there's enough evidence that diabetes is linked to obesity. Now, you talk about very slim people. Some people who are slim like that may have one of these type 1 type like diabetes, where their pancreas have been damaged by either a virus or something, So it depends on the type of diabetes that you probably have and all that. But most people with type 1 diabetes are slim. Most people with type 2 diabetes type 2 diabetes are obese and in their middle age and all that. So in terms of, what's the other question again?
And whether fat and protein can have a burden on the kidneys.
Yes, yeah, that too is important, because I've had situations where I get these muscle builders, who are taking a lot of protein shakes. There's no real hard evidence that can damage, but that can damage the kidney. But there's some form of observational study where they found out that people who are taking this have had some some drop in their kidney function, but that has no hard evidence. Now, keto diet, I'm not entirely convinced that it has any kind of benefit. All what you're doing, you're cutting off carbohydrates. That's what you're doing, isn't it? So, well, they call it a big name, but you're just cutting out that carbohydrate. Keto diet means that your body is using other means of energy to give you energy for your body to function. So I don't think that you can do other things apart from keto diet. Yeah.
Thank you. A person has been diagnosed as pre-diabetic. Do they need to measure their blood sugar every day? And the second question, I think there's quite a bit of interest around the natural side of things. So someone is also asking whether a naturopath could give any input regarding alternative or natural means of managing these conditions. So those two questions, please.
Yes, I mean, let me take the natural side of things. I mean, I don't have any problems with taking natural foods. Natural foods, you can define it. So what do you mean by natural food? Is it the fresh foods you buy from the fresh food vegetable market? That is fine. But what I have a problem with, where this unorthodox blending of stuff and saying that, I mean, people blend fruits and make a fruit shake. I mean, that's the way you want to have your fruits. So that is a choice. So in terms of saying that I should go and meet a naturalist, because I think I want to manage this patient's diabetes. I mean, diabetes, the insulin was found several, I think over 100 years ago now, but nobody has been able to come out with anything from the natural people that this is going to help with diabetes. But it is, like I said, I'm not against natural food, but natural food should be the same thing that we all know as natural foods. Go and get fresh vegetables and fruits.
Thank you. I'm just going through quickly to see if we've missed anything, because we are getting some questions from YouTube coming through as well. Right, Prof, please, why does a diabetic have a high heart rate during the night that wakes them up to find out that their sugar is low and they need to have something sweet? So why does that happen in diabetics, please, Prof?
All right, so the reason is that, you see, in order to maintain your blood sugar for normal people, there are certain things that have to come into play, certain chemicals. You have what you call the adrenaline, you have the cortisol, which is the steroid that naturally produced in your body. You know, you have your insulin, you have all these other things. Now, all these other chemicals, which are quite numerous, but some of them are very tiny, but these are some of the major ones that control blood sugars in normal people. So if you now have diabetes and you're on insulin or something, or you're taking your tablet, at some point in the night, your blood sugar drops. And so your body is releasing chemicals to boost your blood sugars. And one of the chemicals it releases is adrenaline, and that's why your heart rate goes up.
And would there be other signs that might alert people as well, apart from this particular one? What could be some of the other signs, briefly?
You'll be feeling tremors, you'll be sweaty, you lack concentration. It's just like somebody who is, I'm not saying that somebody hungry has hypoglycemia, but I mean, you'll be irritable, you'll be sweaty, you'll be really sweaty, and you will be feeling, you lose concentration. And sometimes it leads to confusion, and sometimes it collapses.
Yeah. So that means it's a very serious disease, diabetes, although there is treatment or management, rather, I should say, for it. It can have very serious consequences. And on that note, I would like to say a massive thank you to Prof. You've given us a wonderful, insightful discussion today. You've touched on a lot of things within this short period of time, talking about diabetes, talking about hypertension, talking about kidney disease, cardiovascular health, and how all of these are interrelated and how they have a multiplier effect. I think the message is crystal clear that we need to take our health seriously. We need to be healthy. We need to do whatever we can to prevent ourselves from getting to this point. The There were loads of questions coming, which shows the interest and the importance of this topic. So Prof, we really appreciate your time and your input. I'm really sorry if we couldn't tackle anyone's question or if there are still stuff coming through, which because of time we wouldn't be able to pick up. Please send your further questions or concerns to health@cahn.org.uk or contact the CAHN team for further information. And if you have anything else you think about later, you can certainly email us. And for those who do want the slides, it will be available. And for those who want to watch it again, it's available on YouTube. So thank you so much, Prof. Unless you want to give a 30-second final word, but I think you probably.
All right. So yeah, I think the take-home message here is that especially when it comes to diabetes, hypertension, cardiovascular disease, it's not rocket science. I mean, it's just simple, and try to make it simple. Lifestyle changes. Don't make anything complicated, especially people. I think that there's a lot of interest within the African community and even Caribbean community on some of these naturalists. There's no problem with that, but do it rightly, and in that way you can help your organs. Don't just go with the crowd to say that, well, people said this. I've had situations where people have had problems after doing all this for quite some time. But make your life simple. So lifestyle changes. If you're diabetic, work with your doctor. You will be fine.
Thank you so much. And thanks to everyone. I'll hand over to the team now to carry on. Thank you.
Thank you so much, Dr. Diane. I mean, thanks for facilitating this so expertly well. We're really grateful for having you. Thanks so much to Professor. I mean, you did an expert work in delivering this, even with, it was amazing the amount of things you're able to cover really, and how you broke it down into simple bits for everyone to take on. That's really, really brilliant. So we do appreciate that. So just to say a massive thank you to you from the team. I mean, it's just to touch on some of the events that we've got coming up, just to keep everyone in the loop. So we've got this week on Friday, we've got a suicide awareness training. My colleagues will be putting the information in the chat box. So please do feel free to register on that and try to attend. It's going to be in Manchester. Then also in June, we've got a Windrush event. It's one of our flagship events at CAHN, and we would like you to please subscribe to that as well. Just try and make sure you register and come along. It's a physical event, and it's going to be in Manchester as well. Just to say, the other thing we've got on, like Prof has already alluded to, there are lots of webinars we've got coming on. The one we've got on Tuesday is going to be on lifestyle changes, just like Prof has alluded to already. So we'll be looking at things concerning nutrition that can help us to make these changes, I mean, to better our health in all essence. Then upcoming also next week, I mean, my colleague is already putting the flyer up, so we can all see that. Still, the theme for this month will be centered on diabetes. So next week, we're going to touch on living with diabetes. And just if you can look through it, you see all through up until the last week of the month. So we're just touching on diabetes and enlightening our community basically on how to make these changes to help us reduce some of all these drastic health outcomes that we currently have amongst our community, really. So just to say a massive thank you to everyone. Thanks for coming along to the call. As always, we've got our services are available and open to all. We've got our counseling service, we've got our advocacy service. You can always access that. Then just send us a mail to help@cahn.org.uk. Otherwise, you can just give us a call. Our details are in the chat box. Please do feel free to use the service. It's open to all and everyone can access that. So a massive thank you to everyone. A massive thank you for you just coming on the call and joining us. We hope to see you again next week. So thank you and enjoy the rest of your weekend.
Thank you very much. Thank you, Diana, for such an excellent hosting. Thank you.
Thank you, Prof, to everybody.
Thank you.
Welcome to our Caribbean and African Targeted Health Improvement Program, CATHIP Health Hour. The Caribbean and African Health Network, CAHN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating, and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members, and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses, and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell, and many more. We have not forgotten to include within our health hours the many societal, cultural, religious and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@cahn.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.